know that there will be questions for Jason. There were some really fascinating slides which we saw. And what I've asked, and Jason, if you're amenable, because I think it fits very much in the next conversation that we're going to have, if you don't mind staying around. Because what we are hearing a lot, and I think one of the phrases that Jason used was holistically putting the needs of the patient as an individual at the heart of all of this. It was that sort of mind shift, if you like, that was pivotal to all of this. And that's very much what we're going to be speaking about next. People-powered health care. That's the way this session is built. And we have some excellent people to discuss just how you do that, how you put the patient in the centre of all of this. Because as you said, without the stakeholders' buy-in, nothing is going to happen at all. We have with us Soma Stout, who's the executive lead of 100 Million Healthier Lives. We heard that mentioned earlier today. We have Don Redding, who's the Director of Policy at National Voices, and Kate Julia, who's the Managing Director of Ayla Danlos Support UK, and also Kate Allatt, a really fascinating person. I'll tell you a little bit about Kate before we even begin. Kate, at the age of 39, had an unthinkable diagnosis. As a young mum, she was told that she had locked-in syndrome. Not only did she pull her way out of that, she also became a pivotal player in what we are talking about now, which is patient at the heart of treatment. She was very much an inspirational figure, speaking about the 5-year forward plan, and I will let Kate tell her own story in her own special way. Please welcome our panel.
Kate Allatt from Dore in South Yorkshire had a severe brainstem stroke and then went on to develop locked-in syndrome. Doctors said she'd never walk or talk again, but the mother of 3 defied their predictions.
How many people suffer from locked-in syndrome, and how hard is it to recover?
Well, it's actually pretty rare.
My speech therapist was absolutely brilliant. However, she did say a week before my tracheotomy came out that Kate would never speak again.
Off we go! Go on, Kate!
In the coma, I was totally unconscious. There was no Disney-fied or anything like that. It was just my life lost 3 days. End of. The psychologist took my friend out of the room, unbeknown to me, and she said, "We have a problem. Kate's expectations are here, and ours are here. You need to bring Kate down to us." And she said, "No, damn you, you need to go up to her." My community stroke team wanted me to practice standing up from seating after I left hospital. Now, I actually wanted to run again by my first anniversary of my stroke. That was in just 3.5 months' time. I thought they were again lowering my expectations. So, being the kind of person I am, she was very nice, but I did sack her. And I blagged free gym membership in return for some marketing work, but unbeknown to me, I was thrown in a personal trainer for free as well. Now, Mike Lee and I worked tirelessly, repetitively, frequently, intensively over the next 3.5 months. And do you know what? In just 6 weeks, he got me out of the wheelchair I was doubly incontinent in. He got me, after another 6 weeks, off crutches altogether. And actually, on my first anniversary of my stroke, I shuffled, as you saw, 10 yards. But you know what? Just 21 months after my stroke, my brainstem stroke, I ran 1.5 miles. It was like a horse, but I did run it. So, but I have to say, when I came home from hospital, I got 3 young children. My youngest was 5. I was lonely. I was isolated. I left hospital after 9 months. They just waved me off. I've had no help, no support, no nothing. I didn't know what I was going to do with my life. I was 40 years old. The people who had come to see me in hospital had gone and dispersed. They'd spent 9 months looking after me in hospital, and as soon as I was home, I was considered well. I wasn't well. I was caught between my old self and my new self with no idea of what I was going to do with myself. On top of that, the post-traumatic stress disorder I suffered. Give you an example. I'd been in Sainsbury's in my wheelchair, but I was actually convinced that was a dream because I was really in the Northern General Hospital in Sheffield, completely paralysed. And then having to come home to be a parent to 3 children who were completely messed up from me not being there for 9 months and after the circumstances, and my husband. I wasn't even well enough to look after myself, let alone the children, but again, no support. But the day I left hospital, as a legacy to my children, because I thought I could get run over by a bus just like that now, I started writing Running Free, my book. It's on Amazon, if anybody wants it. And it was really a legacy for my kids. But you know what? It's a very candid, very in-your-face, very raw, very real story, true story that's turned out to becoming the very big practical guide for anyone affected by locked-in syndrome. It gives people and families the world over hope and inspiration, but practical ideas to help themselves improve their outcomes. I'm very proud of that book. But just 3 months after I left hospital, that's all it took for me to figure out what I was going to do with my life. I figured my way of repetitively, frequently, intensively, obsessively willing myself could help other people. And you know, it really has. Gives hope, inspiration. I give no promises to anybody that are going to do what I've done, just possibilities. I mean, for example, take Christine Waddell. She's the same age as me. When she approached me on a Skype conversation with her carer, she'd been locked in severely in a headrest in a wheelchair, unable to do anything, not eat, for 17.5 years. Okay, we had a conversation, and do you know what? 2.5 years on from that, from the help I also blagged for her, and her ability to work hard, she's changing science. She's actually able to speak a few words. She's in a standing frame. She's doing water therapy. She's able to hold herself up. But you know what? Best of all, up until 2 years ago, all she had to look forward to was 2 vodkas down a peg at night, once a week. But now she's eating 3 meals a day. So much so, she's actually put herself on a diet. And then take Claudia from Poland. I went to go and visit her, 23 years old, had exactly what I had. I spent 3 hours by her bedside, voluntarily doing what I do. And do you know what? She had a bit of belief, a bit of hope, and she had some practical guidance as to what to try. By the time 10 hours later came, I got back to Sheffield, her boyfriend had sent me a WhatsApp of her moving her arm over and moving her body and actually mouthing some words. And she's now gone on to do all sorts of other things. So phenomenal, really. But I've also had Facebook groups that have given digital advocacy all over the world, actually. But what's really fascinating is the people that I helped on my Fighting Strokes page and my Beating Locked In page, they're now helping other people. So the cycle of giving just continues, and it's really, really good. I mean, I found that giving and kindness has really helped me preserve my own mental well-being. You know, I've struggled since my illness with all the pressures on me and everything else. It's been huge, but to help others and to try and make a difference to their lives has really helped me stay on track. In fact, I've worked with the University of Nottingham and I've pioneered some peer mentoring research, actually, and electric stimulation research. And most recently, I've just done a TEDx talk on voicing inner thoughts, if you want to watch it. But I do have to say that I do love to give workshops on how to implement self-management in the primary sector. I really feel strongly that patients need to be given the skills, knowledge and expertise and confidence to be able to manage their own chronic conditions. And I worry that they don't. But I also have a very big passion in the integration of mental health and physical health. It's inextricably linked, you all know that, which is why I'm very much involved in a brand new wellbeing digital hub, Sheffield Flourish in Sheffield. I do want to say this quote from Winston Churchill, which I think underpins self-management from a patient point of view. Success isn't final, failure isn't fatal, it's the courage to continue that counts. And that's my favourite quote. But you know what, I'm going to give the last word to the legend that is Muhammad Ali. He said, "Don't count the days, make the days count." And I think I have in the last 6.5 years, and hopefully I continue to. So thank you very much.
Hey. So, Kate, thank you very much. I mean, absolutely inspirational. And you are way out ahead of me. Soma Stout. No, please do. Because I was just going to say, Soma, it's really good to have you here because we've been talking about partnerships all morning, partnerships between organisations. But in Jason and in Kate, we've heard about the most important partnership of all, which is a partnership between the patient and their health. And with 100 million lives globally, you're trying to sort of rewire a global think on this. Please tell us more about it.
Thank you so much. And what an inspiring story. And I'd like to begin by thinking and reflecting on that story. Because in 100 million healthier lives, which brings together an unprecedented collaboration of change agents across hundreds of communities, across over 15 countries around the world, who have all said that we need to go from thinking narrowly about a healthcare system to really understanding what it takes to create a health and well-being system, we believe that people are the single most important source of trapped and untapped potential that exists in our communities. They are, in our minds, the missing link between where we are now and the outcomes we hope to achieve, but also the bending of the cost curve in what it takes to create health and well-being. And over the next few minutes, I hope I'll share with you some examples of how people globally are beginning to make that journey and why. You know, as we began to think about this, what does it mean to create a health and well-being system? We realized we needed to do several things. We needed to develop healthy, equitable communities. We needed to figure out how we integrate across sectors that create health and well-being, recognizing that healthcare and access to healthcare now in most developed countries only represents a 10% contributor to premature mortality. The reason people die is because of the social and behavioral determinants of health. And if we know that, we can't continually pound on the healthcare system to get the outcomes we need. We need to step back and think what it takes to create that broader health and well-being system. We do need to create a healthcare system that's good at health and good at care, where when Kate goes and says, my expectations, my goals for myself are here, and they say, yes, we're right there with you, that's a response, and how do we help support you to get there? That and how we grow up a whole set of healthcare systems where people are skilled and trained to do that. But above all, how do we unleash the power of people to improve their own health and the health of their peers? How do we recognize that most of the people that we saw in the video that was watching her run were actually not professionals at all? They were people who were just supports that belong to our networks that we never leverage to create health and well-being in an intentional way, in a way where we recognize them as part of the system of health and well-being. To do that, we need to develop new culture and mindset, and we need to develop enabling conditions like the ones Jason was talking about earlier. I'm going to share with you one of the stories that helped us realize that we don't have a choice but to go in this direction. This is a map that Kristen Lind, a patient who a mother of a child with a special healthcare need, drew for us. And what she shared with us was this, that over here in that blue corner of the left-hand side represents the totality of his healthcare system. And there are a lot of boxes there, a lot of bubbles filled with people who are working hard. And we were doing a lot to integrate that system and doing all the things that I think you all are doing here in the NHS. The problem is it was only a tiny quarter when you looked at all of the rest of what she actually needed to support her son, Gabe. And no one was helping her to do that. In fact, she'd had to quit her job because we couldn't see the whole picture. Not only did she have to do that, we actually realized when you see this picture how much more information she has about her life and the life of her son than we do. We could spend forever in a doctor's visit trying to understand this, or even have a social worker try to uncover this, but really, she knows. In the health system that I have the privilege of being a primary care doctor of, where we've been taking this new mindset, changing, looking at our super utilizers and using the model that ask people what their stories are and where they are ready to move and what they need for support, and let that be the guide. We've been able to lower the absolute medical cost by 10% while dramatically improving health outcomes for people. This is actually the simple solution, not the complex one, to see the whole person and to trust that person to be part of how they create health and well-being. So here are some key principles that are emerging for us as we look globally in 100 million healthier lives. The first is that people know more about what is happening in their lives than we ever can. That expertise isn't just something nice we do because we're nice people who want to do patient-centered care. It's critical to understanding the solutions that work. And it gives us the most efficient way of addressing and helping people. Every business that works is designed around its customers, right? We are no different. The second is that our interactions with our patients within the health system have to be co-designed as a result, because patients and people have solutions. The third, health happens in the community in a 5,000 to 1 ratio. 5,000 hours that someone with a chronic disease spends managing their disease at home compared to 1 hour total that they might see their GP. We can't leverage that hour. We need to think what's happening in the 5,000 hours and really build the models that do that. And finally, that people need community to create health. People don't become healthy alone. They need other peers. They need connectedness. And the place and context that they live in needs to create health. In South Africa, peers are actually creating a 95% adherence rate for HIV treatment in peer-led programs. In the diabetes prevention program run by YMCAs all across the country, recently demonstrated across 8,000 Medicare beneficiaries a dramatic improvement in outcomes with a 50% or more improvement in people progressing to diabetes. But above all, a $2,600+ per beneficiary cost savings, a 4-to-1 return on investment. If we can begin to trust that peer-to-peer approaches, we can begin to invest in these approaches in a way that makes sense. And finally, we need to see that people can try to be healthy, but if the places that they live in are being shot and afflicted by violence, that's not going to be successful, or if there are no environments where they can walk. And programs all around the world, such as Jönköping County, where they're building cities where walking is supported, along with creating peer-to-peer supports in the Passion for Life program that helps seniors learn how to engage in their own health, teaches them improvement methods, but applied to their own lives, and is creating a movement of thousands of seniors that are out on the streets of Jönköping County, supporting each other in cafes and using what they call the wheel of life, the PDSA cycle. I'm going to stop there with that story, but I just want to invite all of you to think that we have a huge untapped resource in people, and to encourage you to innovate with us in thinking how we unleash the potential of our people.
Sherry, thank you. Thank you very much. Thanks. So this is almost it's a very visual passing of a baton, because nobody believes more in community and connectivity than Don Redding over here, who is Director of Policy for National Voices, a coalition of national health and social care charities. Don.
Thank you, and wow, what good company I'm in. I think all the previous speakers have so much made the case for me that the best thing I can do is give you a few touch points for things that are happening here, because I think we're actually close to doing something that's quite remarkable, because it's something that our organisations, working with people in holistic ways, have argued for and waited for years. So 16 years since we were promised in a national plan that there will be a patient-centred NHS, we're beginning to see that we're taking steps to get closer to that. The 5-year forward view calls for a new relationship with people and communities, and as the speakers have argued, we're not going to achieve sustainability until we get that. The kinds of new relationships that we're talking about are embodied in this slide, which is the 6 principles. These were developed by the People and Communities Board of the 5-year forward view with the vanguards. They're built into the NHS planning guidance. They're referenced in the guidance for your sustainability and transformation plans. They will be there in the specifications for those new models of care that you've been developing. This is part of the future direction in which we're going. Today we've published a guide. There's a few copies on the Health Foundation's stand, but it's also on our website, to these 6 principles, why they're important, what approaches you could think about using to put them into practice. So the challenge for today, for this conference, is moving towards practice. We're trying to help you get there. Briefly, I'm going to touch on 2 of the principles, because I don't have time for all of them. Principle 1 is about being person-centred. Care is person-centred. Actually, the encouraging thing is over the last 3 or 4 years, we've got to know a lot more about what that means. In particular, using what became 3 years ago the formally adopted cross-system single definition of the goals of integration, which is a narrative for person-centred coordinated care, which we and Kate Allatt helped to develop with NHS England and the Local Government Association. And the integration pioneers have all adopted this and are working hard to get there. Look at their 2-year annual report published in January. Learn from what they're doing. Principle 5 is that the voluntary and community and social enterprise sector should be involved as key partners and enablers in the new design, the new models of care. The key resource here is NICE Guideline 44, revised in March, which builds on work that Jane South has done for Public Health England, and that looks at the evidence and the practice for this family of community-based interventions that help to support not just health, but well-being. There's a lot more that we need to know and need to explore about how to work with people and communities in these new ways. We're part of the Realising the Value programme, which already has some useful publications. Again, they're on the Health Foundation stand, looking at how do we change the nature of what we value in health and care. Because if we want the kinds of outcomes that previous speakers have talked about, if we want to follow what the Confederation's put in its document, joint document released today, about outcomes that are designed and produced with people, reflecting what matters most to them, then we have to change our value frameworks. And that's what we've been exploring in this programme. And all of this, I think, can build on, in fact, the challenges that we all set out together as allies with the Confederation's 2015 Challenge Initiative to reshape care around the needs, aspirations and capabilities of people today, and using the kinds of proven interventions which we've been calling for so long. Care and support planning personalised to people, shared decision-making, supported self-management approaches like those we've just heard about, for all who can benefit. That document said we cannot afford to delay efforts to reshape people's care. We're going to be around to help, to challenge and to partner, but really it's over to you guys now. over the next 3 years, we need to make this shift that puts people and communities in co-production with the health and care systems to create better health and well-being. Thank you very much.
Thank you very much, Don, or should I say at Mighty Dread. That is the best Twitter handle we have on the stage at the moment, let me tell you. We also have Kate here with us as well. Kate, if you don't mind, if we can get into sort of a bit of a conversation rather than I know you and Don are pretty much singing from the same hymn sheet rather than hearing it twice. First of all, if I can start with our friend from across the pond. Jason, when you look at the NHS from where you are, do you see a sick man, a survivor, a system that you envy, or one that just isn't built to last?
Interesting question. It's interesting because in the sense that there was a gentleman, Dr. Don Berwick, who was asked to answer that question a number of years ago. And the way he answered it actually directly impacted his ability to be confirmed to be the head of the Centers for Medicare and Medicaid Services at the beginning of the Obama administration.
Really? Well, we won't don't worry, we won't tell anyone. It's completely safe with us. You just speak freely.
But I guess, I mean, honest answer is I think every system, and we see this in the United States, is that, we are in essence a devolved system of governance when it comes to healthcare. And so the joke in the United States is that when you've seen one Medicaid program in a state, you've seen one Medicaid program, and that they vary substantially across the country. But each and every system has its strengths and its weaknesses. I don't honestly believe there is a single sort of silver bullet or single design that at the end of the day leads to the best and perfect outcomes. I think all systems are a reflection of community values and community history.
Yeah, but with respect, that's not what I'm asking.
Okay, but what I'm saying is that what do I see? I see a system that has its strengths and weaknesses. I see a system, strength, tremendous buy-in from the public in support of the system. That is a tremendous strength. Why? Because it means that the people care so much that politicians, regardless of their stripes, have to protect and look to enhance the system. That's a strength. Weakness is partly also a reflection of the strength. Difficult to change a system and work in an environment where there is such intense, immense pressure on all elements of the system. Strength, you are in essence a single payer system, and so as a result, in theory, you should be easier for you to tack in different directions. We are one payer out of many in New York State. While we are the largest, we are still only a third. In your case, as single payer, you have an ability to do that. That said, you are also a multi-headed hydra with many constituency groups, and that while to outside folks it may look like you are monolithic, in reality you are not.
Okay, Jason, you are entirely the kind of doctor who looks at an X-ray and goes, "You'll be fine." I think. I mean, that's what I'm taking away from what you're saying. You're not willing to commit, but it's a very equivocal answer to a binary question, which is, are we going to make it or not make it?
I think you'll make it. I think there's no question you'll make it. I mean, anybody who thinks that the system is going to, I just would disagree with anybody who thinks the system's going to make it. I think the question is your future trajectory up or is it down? And I think that's a question that affects not only you, but all across the country, or all across the world, is that and we're the poster child for this, which is 17% of our GDP. And while we've historically been able to pay for that because we're the wealthiest country in the world, that ability is diminishing. And the concern that we have now is, and that's why the Affordable Care Act and other things are better, is that we have to begin to bend that curve and slow the growth rate.
Well, I mean, one of the graphs that you showed was astonishing, where your spend came down before the 2000 rate. And if we have time, and unfortunately, we've got a clock ticking, we see a massive countdown. It's as if we are all going to be blown sky high when it goes red. You don't see this, but if we look a little bit under pressure, that's why. But one of the reason, or one of the things that we are constantly told that will bring down costs within our system is for the patient to do more for themselves, that prevention is better than acute care, for example. Now, who is the best? So we start with you, Soma, and then come to you, Kate. Who is the best at pushing that change through? Is it the GP who sees the patient and says, you know what, you have a problem with possible diabetes, you have to do this, this and this. Is it somebody else? Who in this sort of sea of people in that huge graph that you showed us earlier is the best pressure point to affect that kind of change?
I think for key challenges we need to address, such as the epidemic of chronic disease, we actually need a health and well-being system where we're speaking with a common voice across community and health systems. So one amazing example of this is in Maryland, barbershops and beauty salon owners have formed a network because people actually go to barbershops and beauty salons much more than they see a doctor. These barbershop owners have been trained, and this is led by a barber who has been in partnership with somebody working in public health, has really taken this as part of being able to not just be about barbershop owner, but about being a leader in the community. And they're looking at scaling up a national network on this. Similarly, there are groups that there are faith communities that are recognizing that people attend their church or their place of worship once a week, and again, see a doctor a few times a year. And by reshifting their role, not because they're trying to solve our problems in healthcare, but rather because ministers are tired of performing funeral after funeral for people who are dying prematurely and then counseling to the bereaved. Really, they've chosen to take on this challenge and are able to do far more than we would be able to do.
And you've got metrics to show how
absolutely,
this has changed, right?
with outcome differences. And alongside that, I think we need to be, the whole system within healthcare then has to be created to make that prevention easy, possible, and reliable. So that, for instance, in our advanced primary care systems, that what is needed for someone from a prevention or chronic disease management shows up simply in the health record. The patient has access to it before they come in. The medical assistant and receptionist begins to work with them on it. So usually by the time I, as a doctor, enter the room, all of those things have been addressed. The patient is asked to identify their goals for their health and their goals for their visit. And most of our time is spent in motivational interviewing, helping people. It's a very different visit at that point.
Just let me bring Kate, Julia in. Kate, as I mentioned quite a long time ago now, Managing Director of ALS Danlos Support UK, which is the charity partner. For the first time, the NHS Confederation has a charity partner. And I sort of felt you nodding a lot when Kate was talking about that gap between the hospital and home, a gap that you can fall into, not just a well of being forgotten, but a well of despair as well. That seems familiar.
Yeah, absolutely. So I represent people with I'm not going to call it a rare condition, it's a little known condition. Affects people very differently. And I think the challenge there is, the GP may be the first point of contact, but if that GP understandably doesn't understand the condition, doesn't know very much about it, they're not the right person to be driving forward the holistic care that that person needs. And then that's where, for me, peer support, I think, is critical. So in situations that we see every day in our organisation, it's the support of people in a similar situation. So whether that's with the exact type of condition the other person has, whether it's a similar age, a similar family dynamic, they can talk together in a safe environment with people that they know are experiencing the same things. The challenge then becomes that what people can access in one area, unfortunately, isn't available across the country. So while people may have, a great idea of how to go about self-care, self-support, that may not be accessible for everybody. And I think that's one of the challenges that we need to overcome in the 5-year forward view.
Right, and if you have a question, just please put up your hand. Please bat people descend. Don, looking at that graph that you presented earlier, the 6 points, the 6 principles that matter, the word that comes up in a lot of the segments is volunteer. So you're looking for people to put time in. How is this different to the idea of sort of big society, which is now, fairly, can one say tainted? I mean, when the czar of big society says he can't do it anymore because he can't put in the 3 hours, I think we can say tainted, can't we? But how much is that relying on a volunteer sector that we thought we could rely on early on in the tenure of David Cameron and suddenly found that we couldn't?
Well, just because certain people adopt slogans doesn't mean that the slogans don't have meaning. And Andrew Lansley adopted "No decision about me without me," and we would still hold to that principle. The big society, I think, only touched on something which is there anyway, which is that the fabric of civic and community life is woven and built by ordinary people doing ordinary and extraordinary things because they want to put something back. And you can't trademark that. I think what we are trying to recognise increasingly is that volunteering, social action, peer support have value for the people doing them as well as for the people done to, and that what you're building is social connections, social capital, you're fighting against loneliness, you're building people's skills and confidence, you know, and these are the kinds of outcomes that we're talking about increasingly needing formally to recognise in the value frameworks in health and care.
We're on red, but I'm going to take 2 questions anyway, because I'm like that. Who's got a question? Anyone got a question? Yes, there's one gentleman right here at the front, number 2, if you could come. I feel like a Bond villain, number 2. Find that man. Yes, let's have that question there. Maybe we will. I'm just hearing maybe we have time for 1 question.
Isn't it second the best?
Yes.
Awesome. Great. It's really awesome to hear the talk going around social determinants of health. But a theme that we've been discussing today is how difficult it is to connect the different silos just in the healthcare space. So when we're talking about the social determinants of health and inequalities, we'll be looking into the educational space, economic space. How do you think that we'll be able to connect everything?
So who would you like to put that question to? Or shall I just... Soma?
Yeah.
Yeah.
Sure. I think the best way to begin to do that is actually to begin with a particular challenge you're trying to solve, map out who's there. Where we always say if you begin with a question of someone whose life is going to get better because you do this, it drives integration far more than if you say we're just going to do some wholesale integration where people aren't sure exactly why they're doing it and why it matters, but also because then you can begin to map the systems around a particular issue. We're doing this, Jason mentioned opioids. We've been doing that around opioids recently, but also around things like reincarceration and incarceration and reincarceration, as well as childhood asthma. In each of these cases, what we found is that the communities that are making progress have started somewhere. So in our case at Cambridge Health Alliance, we started with childhood asthma, figured out that it was schools and homes where most children were suffering with asthma. And as you could get the school teachers and the school nurse to have access to the registry, and as you for controller meds and have easy access to get preventative medicines refilled, and as a public health nurse visited the home and helped educate the family about and the child about the asthma, but also noticed there's some mold in the ceiling and partnered with the housing department to be able to make that. It was simple cross-sectoral collaboration that led to a 90% reduction in outcomes. And when we saw that, suddenly we were motivated to do that around a range of other issues. And in community after community where we see that in place, you see the beginning point where people begin with things that matter, that we describe as heart points, pain points, or shame points in a community that they're anxious to solve. And as they realize that, then they begin to build the structures that build integration in a more broad way.
I can't think of a better place to leave that. It's a really positive message. Just before we thank a stellar panel, I think, with some really extraordinary stories to share with us, I've got a couple of things to tell you. First of all, some of you will have access to one of these. It's like a Willy Wonka golden ticket. Apparently, NHS Confederation members and their associates can go and see a shady lady at the back of the hall, or a gentleman. There's a members area. I'm not invited to it. But if you get one of these, if you go and see them, you'll get one of these tickets, and then you can get to a lavish reception this afternoon with much champagne. But if you want to be healthy, there's yoga on offer tonight at 7 o'clock. Just look at your programs and you'll find out where to do it. So, you know, the choice is yours. There's booze, there's spiritual enlightenment. You choose. We will just judge you tomorrow. Please do join me now in thanking our entire panel. Thank you very much indeed. See you tomorrow.